Hi, everyone. Welcome. We're just going to wait a few more seconds for people to roll in here. Oh, we got someone in the chat that said, hi, Allison. Michael. Della.
Hi, everybody. Thank you for coming.
Okay, perfect. So we're going to go ahead and start. So good afternoon, everyone, and welcome to today's webinar, COVID-19 Through an ICU Nurse's Eyes, presented by Allison Lindblom. My name is Tenzin, and I'm the CNSA Secretary and Treasurer and a member of the Nursing Science Committee, and I'll be moderating this webinar today. We ask that during this webinar that all participants demonstrate professionalism and respect in all communication. If you have a question, enter it into the Q&A section or raise your virtual hand to ask a verbal question and let us know your name before doing so. And lastly, if you have any ideas or side conversation, use the chat box and make sure it is set to everyone unless you want to send a private message. So without further ado, let's all welcome Allison, who will be presenting today's webinar. The floor is yours, Allison.
Thank you so much, Tenzin. Yeah, I'm really excited to be here, and I'm super flattered that we have so many attendees here on a Saturday evening to learn a little bit more about COVID-19 through an ICU nurse's perspective or through my perspective. So our agenda today, in just a second, I'll give a more thorough introduction of myself, who I am, where I've come from, and then we're going to talk about a day in the life of a COVID ICU nurse. What does a typical 12-hour shift look like when you enter the unit? And we're going to go through a case study. My favorite way to teach and my favorite way to learn is with case studies. I think it makes information memorable and really applicable. So I've created a fictional patient, Mrs. T. We're going to go through her case study. And then at the end, I'm going to go over some impact statements from my colleagues who I've been shoulder to shoulder with for the last 12 months in the COVID ICU. We'll hear what their emotional impact statements are, what they have to say. And then I'm going to open it up to questions and conversations. But if I'm not, clear about something, or if I've confused you and you have a question pertinent to what I'm talking about, fire it away in the Q&A box. And if it's a question for the end of it, or just a generic question, let's leave it for the end of the presentation when we open it up to the whole forum. So my introduction slide is here. I'm Allison Lindblom. I have my BSN, and as of yesterday, I have my CCRN. I'm now a critical care registered nurse certification. So that was exciting to add that to this slide last minute today. I'm an alumni from Cal State Long Beach. That's where I graduated from nursing school. I did my preceptorship in the burn ICU at UC Irvine when I was in school. Upon graduating, I was super lucky and fortunate to get hired into the burn ICU in UC Davis up in Sacramento. That's where my career started. That was my foundation. I was there for just under 2 years when I decided to move back home to the Bay Area. I was hired into the Med-Surg ICU at John Muir Hospital, Walnut Creek. But then when the pandemic began, because COVID-19 is primarily a medical issue, the Med-Surg ICU became the COVID ICU. So that's been my home for the last 12 months, essentially. I function as a bedside nurse, so just a regular schmegular ICU nurse taking care of patients. I also function as an ICU resource nurse, so I float around the ICU and I'm just a resource for my coworkers. I can provide meal breaks, I can provide help with whatever they might need. If a patient's decompensating, can jump in and help. I also can function as a rapid response team nurse, so if there's a patient outside of the ICU who starts to deteriorate or decompensate, the nurse will call what's called a rapid response, and an ICU nurse responds and addresses whatever's going on with the patient. And they also respond to all code blues or cardiac arrests that happen anywhere in the hospital. A more new role for me is as a charge nurse in the ICU. Started doing that a couple of months ago. And last fall, I was a clinical instructor for a Med-Surg rotation for Cal State East Bay, and I plan to go back and instruct one more time this coming fall. I'm studying to become a clinical nurse leader or a CNL. I'm in a master's program right now, and you cannot know me and not know my dog, Remy. He's been a very important piece of my life for the last 12 months. In fact, he's having a little doggy play date today with his best friend. So if you hear any background noise, it's just a little pit bull party happening over here in the living room. And then these pictures are some pictures I snapped of me and my coworkers in the COVID ICU. You can see us in our surgical caps and surgical scrubs. So that's a little bit about me. Let's first start talking about the responsibilities of an ICU nurse. It's really important that we all have an idea of what an ICU nurse is responsible for and what we do before we go much further into this presentation. So we have a lot of roles and responsibilities, but I've broken it down into 6 that I think provide a good umbrella of what we do in the ICU. Number one, we're constantly assessing. Assessing our patients never ends. We know what is normal, therefore we should be able to assess when something is abnormal. When you're critically ill and you're in this unit, the smallest changes can mean huge things. So you need to be able to detect changes quickly and address them immediately. As an ICU nurse, you're not assessing only in the unit, you're assessing everywhere you go in life, constantly assessing everyone around you because it just becomes this second nature thing that you're doing all the time. The second thing that we're it's a very big part of our job is medication management. Patients who are in the ICU are often connected to IV pumps that are continuously running IV medications through what we call a central line or maybe a peripheral IV. These medications are often sustaining life. They're maintaining vital signs, blood pressure, sedation, pain. Often these drips are so important that if they were to run dry or run out and the nurse wasn't aware, it could be a life or death scenario often. So the nurse is responsible for making sure that these drips never run dry and replacing electrolytes based off blood work independently, following your order sets, and just maintaining all the medications that this patient needs. Um, we maintain what I think the general public often understands as life support. Thanks to Hollywood, it's always referred to as life support, but we manage these machines. This is usually refers to ventilators and the breathing tube that, we're going to talk about later, but the breathing tube that's connected to a ventilator is often referred to as life support. The ICU nurse needs to know how to troubleshoot these machines because the first lesson you're going to learn as a nurse, no matter what kind of nurse you are, is Murphy's Law. If something can go wrong, it absolutely is going to go wrong. And when you're in the ICU, again, life or death scenarios, you need to know how to troubleshoot these issues immediately to help your patient. So more examples of what life support might be besides a ventilator would be dialysis machines. We're going to talk about that a little bit later. Implanted devices, lines, drains, tubes, airways, all sorts of different devices and machines that we're constantly troubleshooting and managing. Number 4, a responsibility of the ICU nurse is to be critically thinking and collaborating all the time. We need to collaborate with all the other disciplines. We need to be able to critically think our way through new findings, new assessments, new blood work, new labs, differentiate between an old assessment and a new assessment, and what does it mean if something's changed. We need to be the kind of the spearhead of the plan of care for these patients. If something was a highest priority and now there's a new higher priority for this patient, the nurse is the one who needs to escalate this and implement that plan of care for the patient. That's a good segue into team coordination. No matter what kind of nurse you become, if you are an ICU nurse, the type of people you work with are going to include other types of nurses. So that would be like your resource nurse, your charge nurse, other bedside nurses, medical doctors, the respiratory therapists, pharmacists, physical therapists, occupational therapists, the dietitians, the registered dietitians, speech therapists, palliative care chaplain. The patient themselves is the center of this team and their family. The team exists no matter what type of nurse you are, but that's an example of what the team looks like in the ICU. These Team members other than the nurse cannot be side by side with the patient for 12 hours like the nurse can. They have dozens or hundreds of patients that they're rounding on. They can't know everything about everyone. They're dependent on the nurse's charting and assessment to help them do their job and to provide the best service for that patient. So team coordination and effective communication is a big responsibility for the ICU nurse. And then the last thing, which I'm probably the most passionate about, is maintaining dignity. Um, with these patients, they're often sedated, and we can't always talk to them and know them as the person that they are, but it's so important to remember that that person in that bed is a very important person. They're loved by a lot of people and they're under my care. And so I need to maintain dignity for them to make sure that, they and their loved ones can have peace of mind that somebody is caring for them the way that they deserve to be cared for. So that includes keeping them clean, um, covered, decent, bathing them, turning them, making sure that they're positioned comfortably. They can't really always tell you if they're comfortable, so you just kind of have to look at it and think they don't look very comfortable, and fix it. And always talk to them, even if they're sedated, medically sedated. You never know what somebody can or can't hear. Hearing is such a weird sense. You never really know if somebody is there or not. So me as a nurse, and I always encourage family members, if family members can be at the bedside, to please talk to the patient, therapeutic, nice, loving things, because you just don't know what they can hear. And then a big part of maintaining dignity is roping the family in with phone calls and video calls, which for most of the COVID ICU patients is the only way that family can communicate with them, because in the COVID ICU and throughout majority of the pandemic, visitation policies did not exist, simply because we didn't know, how infectious this really was. So nobody was allowed in the COVID ICU except healthcare workers. So we're gonna move on and talk about a day in the life. So you're driving to work and you're showing up for your 12-hour shift. I work night shift, so I work 7 p.m. until 7:30 a.m. So I arrive to work a little bit early. It's pre-shift. I haven't clocked in yet. I'm going to go ahead and gather my surgical scrubs, which you saw pictures of in that first slide. They're just those regular cotton light blue scrubs. I'm going to put on a surgical cap, which you also saw pictures of a few slides back. China came out with some studies that said that COVID-19 can survive for days in your hair, which is probably one of the most terrifying things I ever learned in the pandemic. So absolutely have to protect your hair and wear a surgical cap. And then gather your PPEs for the shift. That might be an N95 and a face shield. It might be a PAPR, which is that crazy looking hood in the slide right there, or a capper, which is the helmet-like thing that you might have seen before. You clock in, and then it's time to go to shift change and to get report. I think that picture is absolutely hilarious because the nurses look so happy to be talking to each other. I'm always happy to see my coworkers, but I'm not usually that happy. The offgoing nurse might be that happy because they get to go home. So you're going to get report from the offgoing nurse. They're going to give you their assessment of the patient. What is going on with the patient, what drips are running, what kind of life support machines are we managing, what are the settings on these machines, what is the plan of care, what has been done, what needs to be done, what do I need you to do on the shift tonight. These are the sort of things we're going to talk about in report. We're going to talk about family issues. We're going to talk about anything that helps me do my job better, basically. Now, sometimes the patient is so sick and so unstable that you just hit the ground running. You have no time to do anything except get to the patient's bedside and start assessing them and start working. But time permitting, patient permitting, ideally you're going to review. You're going to open up the electronic medical record. A common platform for this is Epic. You're going to open Epic, for example, and you're going to start reviewing the chart. There are patients' labs, what orders exist, what medications exist. You're going to use what we call a nurse brain. It's a piece of paper, and it has all of the essential information you need to know for your patient on it. And it's going to have each hour of your shift on it. And you're going to write under each hour what medications are due, what procedures are due, when do I need to draw labs, X, Y, Z. This is your brain. This is going to keep you organized because this is going to be the longest and shortest 12 hours of your life. So this is what you need to stay organized. Again, time permitting. The next thing you're going to do is go actually assess your patient. You need to see them, listen, touch, observe, and start charting your findings. You're going to be charting every single little thing that you do or see or witness through your entire 12-hour shift. Charting never ends. A quick note is in California, we're super blessed to have patient ratios. The patient ratio in the ICU at a maximum is 1 nurse caring for 2 ICU patients. That's the most common ratio you'll see. Sometimes, we're going to talk later about this in the presentation, is sometimes a patient is so sick and needs so much attention that it is a 1 nurse to 1 patient ratio. In rare situations, a patient can be so unstable, so much is going on that it's actually 2 nurses caring for 1 patient. Oh my gosh, sorry, the dogs are barking. So the next thing we're going to do, time permitting, is we're going to call family. Visitors are not allowed during the pandemic, so it's important for us to be the liaison between the patient and the loved ones. They're going to be getting FaceTime calls from us or speakerphone calls. The visitation policy, like I said earlier, does not exist in the COVID ICU. So we need to be the liaison to make sure that these families are able to communicate with their loved ones somehow. We're going to start charting. Well, we're not going to start charting. We're going to keep charting. Charting never ends. More meds, more assessments, and help your coworkers, time permitting, as able to. Now, completing orders. This is a big part of our job in the ICU. Orders are going to be coming in through your shift. You're going to be communicating with the doctor about issues that are going on with your patient, and they're going to be throwing in orders into Epic as your shift goes on. As the orders come in, they're coming in for a reason. They're going to guide the plan of care for the patient and make changes for the patient. So it's really important that when these orders come in, you do them quickly, immediately, ideally, because they're going to make a difference. More meds, more charting, and repeat. Repeat all of these things over and over and over again until the end of your shift, until it's time to give handoff to the day shift nurse who's going to come on and relieve you. This is one more thing that I want to mention really quickly is a day in the life of the ICU nurse. I can't tell you how many times I told loved ones and family members, I wish I could just wear a GoPro on my head and let you all see what it is that I see. And the New York Times opinion piece actually did exactly that. It's a 15-minute long video. Go ahead and take a screenshot of this or snap a picture on your phone. This is something worth looking up on YouTube. You can see the title on the bottom of the screen. It's called Inside a COVID ICU Through a Nurse's Eyes. Like I said, it's from the New York Times opinion. And it basically just follows around some COVID ICU nurses. It does show actual critically ill patients, which might be surprising to people who have never seen an ICU patient before, of how not like a human, sometimes you can look laying in that bed. But I think the documentary says that the families consented to allow their loved ones onto this documentary. So it's 15 minutes. It's really worth your time. Tenzin, are there any questions? I'm going to start the case study if there's no questions that I can address at this time.
No questions so far, so I think it's fine to proceed.
Okay, so we're going to talk about a fictional patient, Mrs. T. Mrs. T is a really good representation of a very typical scenario that we've seen way too many times in the ICU. So who is she? She's a 67-year-old female, Hispanic wife, mother, and grandmother. She has a pretty unremarkable past medical history. She has controlled diabetes. According to her BMI, she is considered obese, and she has borderline hypertension. So controlled diabetes, meaning that she takes some kind of medication management at home to keep her diabetes under control. And her borderline hypertension is basically, we're going to keep an eye on this blood pressure, maybe give her a low dose antihypertensive medication once a day to try and keep it under control. But other than that, she hasn't had any major, surgeries or no history of cancer, nothing like that. Pretty unremarkable besides those things. What does she do? She's a retired school secretary. She spent like 35 years being a school secretary for a school district. So she's really well known and beloved in her community. She lives in a multi-generational household with her husband, her daughter, and her grandkids. Her response to the pandemic was that she was really scared. She was really nervous. She wouldn't go out and go shopping. Her daughter would do all the shopping. Anytime anybody was leaving the house, she always made sure they had at least 2 masks on them. She was very nervous about it. But back in February, her daughter and her grandkids actually attended a backyard barbecue. It was about 30 people. It was mostly like immediate and extended family, maybe a couple of family friends in there. So they felt like it was pretty low risk. It was outdoors, it was people that they know, that they're related to. However, there was like a family style food station, like a serve yourself kind of food station. So there was a lot of potential for cross contamination. And so it's not really known who it was. Maybe the daughter, maybe the grandkids, but somebody picked up the virus at the barbecue and brought it home to Mrs. T, and Mrs. T fell ill. So she was diagnosed on March 1st. She went to an urgent care center because she wasn't feeling well. She had all the, the classic symptoms that the news kept talking about. She tested positive. They sent her home with an albuterol inhaler and instructions to sleep on her stomach. We're going to address both of those things way more in depth a little bit later. And then things got worse for Mrs. T. On March 3rd, she went to the emergency room because she just could not catch her breath. Despite the albuterol, despite laying on her stomach and all those other crazy things the doctors and the internet were saying to do, nothing helped. She couldn't catch her breath. So when she went into the emergency room and they put a pulse ox on her finger, her oxygen saturation was 72% while breathing regular room air. I would venture to guess that most of us today, without any kind of underlying respiratory issues, are probably satting greater than 96 or 97% on room air. So 72%, it's no wonder she feels like she can't catch her breath. She was admitted into the COVID unit on a nasal cannula. So she was admitted not into the ICU because she's not critically ill right now. My hospital, we refer to this as like a COVID med surge unit. So this is a unit where she's going to have a nurse who's caring for up to 5 patients. She's pretty independent in this unit. She doesn't need one-on-one constant supervision, but she needs some oxygen and she needs a little extra attention. She needs more help than she could ever give herself at home. So that's why she's in this unit. So there's a graphic on the left side of the screen here. So she has a nasal cannula, looks just like that in place, and it's anywhere between 2 to 4 liters of oxygen. And she's always satting greater than 90%, getting 2 to 4 liters of oxygen through her nasal cannula. So she's cruising along. She's doing okay. She's not critically ill by any means yet. She gets out of bed by herself. She sits in a chair most of the day, which is great for opening up her lungs, opening up all that lung volume. Really good. The nurses are cheering her on, encouraging her. She's eating her meals. She has a decreased appetite, but that's totally relatable because when I don't feel well, my appetite is decreased too. But she's staying hydrated, drinking plenty of water. She will get short of breath when she moves around her room, but then when she sits down, she can catch her breath. She calls her family regularly. That gives them so much peace of mind to be able to hear her voice. She's talking to them like once an hour, like she's calling them all the time. And she has a dry, persistent cough. So what are we doing for medical management for Mrs. T when she's in the med-surg unit? The first thing we're doing is we're covering her high blood sugars with insulin 5 times a day. So remember, at home, she had controlled diabetes. So she was probably just taking like a tablet, and a tablet would help her maintain glycemic control. But when your body is sick, your metabolism sort of goes rampant. And when your metabolism goes rampant, you can expect your blood sugars to be high. The problem with having high blood sugars when you're sick is that it's going to compromise your vasculature. It's going to make it harder to push around syrupy, thick, sugary blood. It's going to make a perfect environment for bacteria to grow in your bloodstream because bacteria love sugar. And so it's really important to maintain tight glycemic control whenever you're sick. This is really true for type 1 and type 2 diabetics. So we're giving her insulin injections 5 times a day to make sure that we have tight control over her glucose levels. We're controlling her blood pressure with a medication called metoprolol. It's just a twice a day or once a day tablet, pretty low dose or standard dose, and it's doing a good job at keeping her blood pressure under control. The doctor has ordered azithromycin to be injected through her IV to prevent secondary pneumonia. So this is a really important thing to make sure that everybody understands. I really wish the general public knew this. Azithromycin is an antibiotic. It kills bacteria. So think of it like antibacterial. An antibacterial or an antibiotic will never kill a virus. Only an antiviral medication can kill a virus. So that doesn't make any sense. Why are we giving something that kills bacteria to somebody who has a viral infection? The problem is when you have a COVID-19 infection as severe as Mrs. T has right now, the inside of her lungs, deep in her lungs, is the perfect environment for bacteria to thrive. There's lots of protein because her lung tissues are starting to kind of slough off. It's extra moist because there's extra secretions. It's dark, it's warm, and her airways are so tight because they're so inflamed from the infection that she's not able to effectively clear her airway or cough up all these secretions. So it all just kind of sits down there. That is the perfect place for normal flora or bacteria that we know exists in the lungs to start growing out of control and thriving. So that would lead to secondary pneumonia. That would lead to a second type of pneumonia on top of COVID-19. If that were to happen, there's a lot of scientific evidence that the long-term outcomes and the morbidity and mortality outcomes for these patients is far worse. So the goal with prescribing azithromycin in the hospital setting is to prevent this secondary type of pneumonia. Lastly is albuterol. So what you see in the top left of this screen here is called a nebulizer. Now, you can have albuterol in a little inhaler, like what you see little kids on the soccer field with. That's one type of inhaling albuterol. This nebulizer is a little bit more effective because it actually aerosolizes the albuterol so that the albuterol can get really deep in your airways and lungs. What does albuterol do? It's a bronchodilator. So right now with COVID-19, like I said, her airways are tight, they're inflamed. It's hard to get air to pass through because there's so much friction because they're so tight. Albuterol as a bronchodilator is going to give larger airway passage throughs for the air to go. So it's going to allow better facilitation of air going in and out of her lungs. It's going to make breathing easier. Things start to change for Mrs. T, unfortunately. And this is kind of the natural progression that you often see with patients that ultimately end up in the COVID ICU. So let's start on the left side of the screen here. She was anywhere between 2 to 4 liters of oxygen through her nasal cannula. And now she's requiring 4 liters all the time. She sat up in a chair for meals. She's not sitting in the chair all day long like she was earlier. And she called her family for just 30 minutes today. She's not calling them like every hour like she was originally. She does get wheezy randomly, but it improves with albuterol. Her vital signs at this time look like this. Her heart rate is 92, so it's on the higher end of normal. Remember, 60 to 100 beats per minute is normal, so 92, she's on the higher end of normal. Her blood pressure, as a nurse, I'm pretty content with that for being borderline hypertensive, 129/75. She's satting 93% on the 4 liters nasal cannula. So it's okay, but let's keep an eye on it. She's breathing 23 times a minute. I would venture to guess most people here without any underlying respiratory issues, so long as you're not listening to this while you're working out or jogging or something like that. If you're just sitting and relaxing, I would venture to guess you're breathing anywhere from 16 to 18 times a minute. So 23 is a little elevated. And she has what I call a low grade temperature, 99.0 degrees Fahrenheit. Things get a little worse. Now she's requiring 6 liters nasal cannula. She only sat at the edge of bed for 10 minutes. She's texting her family. She's not calling them anymore. And she's wheezing constantly. The nurse is noticing, even if it's not audible without a stethoscope, with a stethoscope, or audibly without a stethoscope, she's wheezing all the time, despite albuterol. Things progress again. So the maximum amount of oxygen that you can give through a nasal cannula is 6 liters. She has graduated off of a nasal cannula and onto a mask. It's not the kind of graduation that you want for yourself. So the mask is now delivering 8 liters of oxygen. She won't get out of bed, despite encouragement from nursing and physical therapy. She has that dry, persistent cough more often. Her wheezing is still constant, but louder now. And she tells the nurse, I just want to sleep. It's not something that I ever really like to hear from somebody who I know was up and mobile and doing things independently. And now they're telling me that they just want to sleep and be left alone. I don't really like that. Now the med-surg nurse calls a rapid response. The med-surg nurse calls a rapid response because they find Mrs. T lethargic. She's febrile. She's hot to the touch. She's breathing fast and shallow. She's not taking deep breaths. So you know she's not getting air deep in her lungs. Her air is high up in these upper airways. It's not very effective. Her oxygen levels are dropping, and so they call the rapid response. The rapid response team nurse would be, for example, like me, or an ICU nurse who's trained to go to rapid responses. They're going to put her immediately on a non-rebreather. They walk in and they see this picture. They're just immediately, they know she needs oxygen. Even if you have no other data, you know she needs oxygen. So you're immediately going to put her on what we call a non-rebreather. We'll abbreviate it as an NRB, a non-rebreather mask. Delivers a minimum of 15 liters of oxygen a minute. So knock on wood, never seen it, but I've heard a lot of the airplane in services where they say the oxygen mask is going to drop down and air is flowing, even if the bag doesn't inflate. Like I said, never seen it, never want to see it, but that's totally not the case for a non-rebreather. A non-rebreather, absolutely, the bag needs to inflate. If the bag doesn't inflate, you're not using it correctly and you're actually going to do more harm to your patient than good. So the bag needs to inflate a minimum of 15 liters of oxygen running through the non-rebreather. Her vital signs, 121 beats per minute is her heart rate. So she is what we call tachycardic. So it's all about perspective when you think about a heart rate. I always think about, okay, what would it take for me? I'm a lot younger than Mrs. T. I'm probably, I'm going to guess, in better general like fitness and endurance health than Mrs. T. It would take me speed walking for maybe 5 minutes to get my heart rate to sustain at 121 beats per minute. I would be breathing a little heavier, but I'd be speed walking. For Mrs. T to get her heart rate to 121 beats per minute, you have to recognize it's going to be easier for her to get her heart rate elevated than it is for me. So I have to think then Mrs. T is working harder than probably speed walking, and her heart rate is sustaining there. And her heart rate's already under stress because she's febrile. She's 101.5 degrees Fahrenheit. She's hot. So her heart is hot, it's beating hard, and it's beating fast. It's obviously trying to compensate for something. That makes me really uncomfortable as a nurse because I don't want her heart that stressed out for that long. Her blood pressure is high. I don't like that blood pressure either. It's higher than what she was trending. She was trending here and now her blood pressure is up here. Something's changing inside of her cardiovascular system. 140 over 79. Probably I'm going to explain this away in my head for this exact moment as she's in like that fight or flight, stressed out feeling inside of her body. So she's going to be a little hypertensive. She's satting 81% on a non-rebreather. I am absolutely not okay with that. She needs a more effective oxygen delivery system. We're going to talk about that next. And she's breathing 31 times a minute. 31 times a minute. It would encourage, if you don't know what that feels like, set a 60-second timer and try to breathe 31 times in that minute. That's very uncomfortable. That's like I just finished a dead sprint and now I'm out of breath. That's very uncomfortable, and she's sustaining that. So she's got her diaphragm, her muscles, her airways, everything is going to get really tired if she keeps working that hard for a prolonged amount of time. So what are we going to do? The rapid response nurse. So we're going to connect that non-rebreather to a portable oxygen tank. You've seen them driving down the highway, those big trucks that have all the green tanks in the back. So a little miniature version of that, a green tank sitting next to Mrs. T on the bed, hook the non-rebreather onto that, crank it up to 15 liters so that we can give her the amount of oxygen that she needs in a portable fashion when we go to the ICU. The ICU nurse is going to attach her to a transport cardiac monitor. It's a big monitor. It'll sit on the foot of her bed and it'll be connected to an EKG. It'll be connected to her pulse ox. It'll be connected to her blood pressure cuff so that the nurse can continuously monitor her vital signs when we're en route to the ICU. Probably the rapid response nurse is going to order a stat chest x-ray and stat labs. They're going to do this now because they know that the doctor is going to have this information already available when she arrives in the ICU. An x-ray is going to show the doctor how far her pneumonia, how far her COVID, how far the damage inside of her lungs has progressed from when she first came into the emergency room to now. I guarantee it's going to look significantly worse. The doctor needs to know how bad it looks, and they need to make sure that there aren't any other issues like a pneumothorax or air collecting on the outside of her lungs, for example, would be one thing that they're trying to rule out to explain why she's decompensating like this. The lab work is going to tell us about her blood count, her electrolytes, all sorts of other things that might guide what kind of things the inside of her body needs right now that we can supplement or provide for her. Once we have all this underway, we're going to call the ICU doctor. They might, if they're not already tied up with something, they might actually go to the rapid response and assess the situation for themselves. But often they have to be in 5 places at once. So you can give them a quick phone call, say, hey, I'm here with Mrs. T. This is what her vital signs look like. This is what she looks like. This is what I've ordered so far. What do you want me to prepare for you? We're going to go to the ICU now. The doctor will tell them, I want to do this, I want to do this, get her going on this type of oxygen, whatever it might be that they want. Where I work, we have the most incredible respiratory therapists probably in the whole wide world. And I don't have to call them. I guarantee they're already going to be there at the bedside. They're going to be doing all sorts of stuff that I didn't even think to do in terms of airway protection or whatever it might be. But if for some weird reason the respiratory therapist isn't there, I'm going to call them because I need to coordinate a plan, an oxygen delivery plan that's better than the non-rebreather, because that is a temporary solution. Nobody just hangs out with a non-rebreather mask. She needs something more effective. And once we have all of that ready to go, we're going to roll out as fast as possible and get her into the ICU, where we have the people and the resources and the tools to give Mrs. T what she needs. I keep talking about a better oxygen delivery system. So I have here numbered 1, 2, 3, the way that the typical COVID ICU patient is going to progress through the options that we have of ways to give them more oxygen. Let's start with number 1, heated, humidified, high flow nasal cannula. That's such a mouthful. Nobody walks around saying heated, humidified, high flow nasal cannula for 12 hours. There is a brand name called Vapotherm. So for the most part, we just say Vapotherm. So that's what I'm going to say. Vapotherm is like a bigger, more sturdy, more rigid, heavy duty nasal cannula. You can see it on the woman in the top left there. It's actually like can cause skin breakdown and damage behind the ears because it's so heavy. So it's really not the same as a nasal cannula. It's more heavy duty. And what it's doing is the prongs inside of her nose are delivering a very aggressive, heated, humidified airflow. Sort of like if you stuck your head out a window on the freeway, the type of airflow that you'd feel up your nose is what it's delivering. But it's warm and it's humidified so it doesn't dry out your sinuses. And it's delivering air that you can titrate. You can titrate how much oxygen is in this air. So the maximum settings that you can provide with somebody on Vapotherm would be 40 liters of flow and 100% fraction of inspired oxygen. So 100% of that air is oxygen. 50% FiO2, half of that air is oxygen. You and me breathing room air right now, room air is 21% FiO2. So 21% of the air that we're breathing right now is oxygen. The rest is other things. I don't know what, other things, chemists would know. So the most amount of air that you can deliver through Vapotherm is 100% of it as oxygen. So put that in perspective. If that's what Mrs. T is requiring, she's requiring 5 times as much oxygen as I'm requiring to maintain a normal oxygen saturation level. If the Vapotherm is not enough, and we're not able to get her comfortable, get her breathing more normally and maintain a good oxygen saturation and blood work, then she's going to graduate to a BiPAP machine. So this is a pretty old school BiPAP. They're a little bit, I don't know, more fancy. The ones that I've worked with are a little bit more fancy than this, but this gives you a really good idea at the bottom left of the screen here, what a BiPAP machine looks like on your face. It needs to be sealed at all times. The goal is to have zero leak of air outside of the mask. It's like this silicone that sits against your face, and it's secured to your head with a strap around the forehead and a strap around the jaw and neck. Again, you don't want any air leaking in and out. The way the BiPAP works is it's going to force air in, suck air out. The idea with a BiPAP is it's taking off the work of breathing of a person. Remember, she's breathing 31 times a minute. Her diaphragm, her abdominal muscles, her accessory muscles are going to be exhausted. So we need to take off the work of breathing by forcing air in, sucking air out. That's why it's called bi, two things, pushing air in, sucking air out. You can titrate all sorts of different settings on the BiPAP. This is totally respiratory therapist's world. Typically, a nurse will know a little bit about BiPAP, but all the special settings and things that you can change on it on a BiPAP and a ventilator, that is what respiratory therapists go to school for 2 years for. So they are totally like the gurus and specialists at this. But in general, you can't exceed this, but in general, the safest maximum amount of positive pressure that you can deliver through a BiPAP would be 25 centimeters of water. I can't even conceptualize what a centimeter of water really is. I'm sure a respiratory therapist can, because again, this is their specialty. And 100% FiO2. Those would be sort of the safest maximum settings that you can deliver. If the BiPAP is not sufficient, and if an individual on BiPAP continues to deteriorate, there are really only two paths to go down. The first path is if the patient is a DNR or a DNI, do not resuscitate or do not intubate, then they will never get a breathing tube. The durable power of attorney, it can be more complicated than that. It's not black and white, it's always gray. But if a person values that they never want to be connected to a ventilator, never, ever, ever, they're 93 years old, if this is my time, make me comfortable, then what we're going to do is we're going to communicate with the family, tell them their options, and sort of go more in that comfort care kind of direction. If somebody wants to, I guess, continue to fight and do the most invasive thing, the other option is they're going to graduate off of the BiPAP and they're going to get a breathing tube. That's number 3, an endotracheal tube, an ET tube. That's how we refer to it, an ET tube. This is what's connected to a ventilator. So look at the graphic. So there at that man's mouth is the ET tube protruding out. It is a hard, I think of it as like, a McFlurry from McDonald's comes with the spoon, and the top of the spoon has a diameter like that. And you always think that it's a straw, and it's not a straw, it's a spoon. That size diameter is the ET tube. And it's hard, it's rigid. I mean, it's a little pliable, but for the most part, it's really hard. Typically a doctor or an anesthesiologist or a CRNA, and in some places, not typically in California, in some places, a respiratory therapist inserts the endotracheal tube. It requires sedating and paralyzing a patient to get the endotracheal tube in place because it is such an aggressive and invasive procedure. It's going to make people want to puke because you're triggering that gag reflex. So you need to paralyze people. And in order to paralyze somebody ethically, you have to sedate them too. So an endotracheal tube goes through your mouth into your airway. It terminates a centimeter or 2 above the carina. The carina is where your left and right bronchus branch. So the endotracheal tube sits above that, because if you think back to anatomy, physiology, if you trigger that carina, you're going to trigger the cough reflex. You don't want to do that. The tip of the breathing tube sits above that. So the endotracheal tube will be connected to the ventilator, and the ventilator is going to be delivering all sorts of different settings that you can choose from of how to deliver this breaths and airway and oxygen. You can have settings where the patient is sort of in control of their breathing, or you can have settings where the patient has no control over their breathing, and everything in between that. This is a medical doctor, an ICU doctor is ordering what they want their settings at, and it is a respiratory therapist's responsibility to change and modify these settings as needed. It is the nurse's job to understand what we are doing, why we are doing it, and how to troubleshoot it. The nasogastric tube is in place. A nasogastric tube is a tube that is inserted through the nose and drops down into the esophagus and terminates in the stomach. It can go through the nose, which would be a nasogastric tube, or the mouth, which would be an orogastric tube. They always terminate in the stomach or just beyond the stomach if you go through the pylorus and then you're in the jejunum. So why do you have to have a nasogastric or an orogastric tube in place? Why? First of all, in emergency, to decompress the stomach. If somebody starts vomiting, they have a very high potential of that emesis going up their esophagus, down their trachea, and around the breathing tube, develop aspiration pneumonia, very high risk for acute respiratory distress syndrome, or ARDS. That's a very, very painful and bad pathway to go down. And for the nursing students out there, that's more of an advanced ICU concept to think about ARDS and things of that nature. But understand that if a patient aspirates their own emesis, which is a very high risk when you have a breathing tube, because remember, we're triggering that gag reflex, very bad outcomes for that patient. So the nasogastric orogastric tube gives us a way to decompress their stomach of air and emesis if we need to. When you have a breathing tube, you cannot speak, you cannot swallow, you cannot drink, you cannot eat, because we are bypassing all of those anatomical features with the hard breathing tube. So the orogastric or nasogastric tube is the way that we can deliver medication, artificial tube feeds, and water into your body. This is how we would crush and we would dissolve medications and flush it down your nasogastric tube. And then to give protein, nutrition, all the things that you'd get from eating, we deliver that with artificial nutrition, or we call it tube feeds. So that's kind of a quick overview over, what the ventilator and the breathing tube really looks like. Please keep in mind that a typical patient, now there's always exceptions, nothing's black or white in nursing, everything's gray, but a typical patient would be so uncomfortable with a breathing tube in place that they need to stay sedated, because their instinct is going to be to reach up, grab the tube, and yank it out, because it's making them have a gagging sensation. So a typical patient is going to have sedation and pain drips running continuously. And they're also going to have soft bilateral wrist restraints on their wrists, tying their arms down to the side of the bed so that they physically cannot reach and grab the tube. Now, all the nursing students up there know that we're assessing the skin underneath these restraints at least every 2 hours, 2-finger size looseness. I don't know how to say that, looseness and the restraints. And we're never restraining somebody unless they need it, but to be intubated typically warrants a restraint. So this is Mrs. T's vital signs now. She's still, I don't know, some people call 100 beats per minute tachycardic, some people call that normal sinus, but her heart rate's elevated. It's 100 beats per minute. Her blood pressure is better than it was earlier, 129/66. She's satting 88%. But let's say that her vent settings, she's getting 100% FiO2 and she's satting 88%. That's really bad. She's breathing 27 times per minute on the ventilator. So she has some kind of ventilator mode that allows her to trigger her own breaths. She is tachypnic. She's breathing too fast, 27 times per minute. And she is hot. She's febrile, 101.1 degrees Fahrenheit. Her fever hasn't broken yet. So she's intubated. We just saw the vital signs. The family are now the decision makers because Mrs. T is going to be sedated, can no longer make decisions for herself. Her blood work, her oxygen work, we're going to talk about arterial blood gases in a minute. So we call that an ABG. Her ABGs really don't look very good. We need to be more aggressive. We need to do more for her because she is not getting enough oxygen. That means that all of her vital organs are being deprived of oxygen every single second that goes by. So we need to do something about that. We need to get this woman some oxygen. And our best ventilator settings with 100% FiO2 and a breathing tube, none of that's enough. We need to do more for her. So what can we do? We can prone her. Proning a patient is a really big deal. This is something that you will absolutely need a doctor's order for, and a doctor really needs to be present for the actual proning of a patient. So laying on your back is called supine. Laying on your stomach is called prone. So that's why we call this prone therapy or proning a patient. It means we are going to flip this patient off their back and onto their stomach. But this is a really big deal. This is something that is reserved for the most sick and most unstable patients. It's not really a Hail Mary because it's a well-known science and it really is very effective, but it is kind of one of the last things that we're going to do because it is so dangerous and invasive. So think about all the things that are coming out of this person's body right now. They have a breathing tube, which is their airway. We cannot lose that airway. If we lose that airway, we're talking about a life or death situation at this point. Mrs. T probably has a central line. A central line is a large bore, think of it like a large bore IV with many different ports, and it's probably either in her neck, under her subclavian, or in her femoral groin area. That central line, again, is delivering life-saving medications, life or death scenario if that central line gets pulled out. She is connected to all of her leads, EKG leads, pulse ox leads, blood pressure cuff. Everything is connected to the monitor so that we can monitor her vital signs continuously. She might have chest tubes, which are large tubes that go through the ribs to the side of the lungs to drain excess fluid or air that might be leaking out of the lungs. She probably has a Foley catheter. She might have a rectal tube. She probably has an arterial line. These are all things that we cannot lose. We cannot have them inadvertently pulled out. So it requires a large team of people in that room to make sure that she can flip onto her stomach safely without losing or dislodging any of these life-saving lines, tubes, drains, and airways. So at a minimum, you need 2 registered nurses, 1 respiratory therapist, 2 lift team technicians. I've been blessed my whole career. I've always had a lift team in the hospital that I've worked in. Not all hospitals have lift team. If you don't have a lift team, which are the most incredible people in the entire world, if you don't have a lift team, then you need to have at least 2 very strong people. And you need 1 ICU doctor present for the proning therapy. So the doctor is there because it has been very well known for patients to code or go into cardiac arrest or a lethal cardiac rhythm when we flip them onto their stomach. You need the doctor there to help you run that code. If that patient codes and needs to have CPR, need to get the crash cart, need to start pushing all of those life-saving code medications, you really need the doctor there to help facilitate this. Imagine if the breathing tube came out while you're proning. You need the doctor there to emergently reintubate. If you lose your central line, you need the doctor there to emergently place a new central line. The doctor absolutely has to be there in case all these things, any of these things go wrong. So that is prone therapy. When you have a patient proned, you can have different schedules. The schedule that we would mostly adhere to in my unit was 16 hours prone. So they're going to stay on their stomach for 16 hours, 8 hours supine. 16, 18, not 18, 16, 8. You can still, we're turning Q2 hours, we're turning every 2 hours to protect skin. You can still kind of stuff a pillow side to side, and you're going to rotate the head and arms every 2 hours to protect the skin and the like mucosa and everything going up on the head. But when a patient is supine for 8 hours, their face, their eyeballs, their oral mucosa, their lips, everything is going to be so swollen because gravity is pulling all of their blood and fluids towards their face. So ice packs when they're supine is really important. So please just understand that prone therapy is an extremely invasive thing to do for somebody who's intubated. All right, I promised that we would talk about ABGs a little while ago. I don't want to spend too much time on this because this is a very advanced ICU concept, but if there's any nerds out there like I was, I knew that I wanted to be an ICU nurse all along, and so I would have loved to have learned a little bit about this before I was a registered nurse. So what is an arterial line? Let's talk about that first. An arterial line can be in the top right of the screen right here. It looks like an IV catheter, but it's not an IV catheter. It's an arterial line. An IV catheter, intravenous, goes inside a vein. This is an arterial catheter. It is inside of an artery. You can do it typically in the radial artery, which is right here, or the femoral artery, which is near the groin. The radial artery is preferred because it's cleaner, easier to access. What does an arterial line do? Well, the thing that it's really designed to do is to give you a continuous blood pressure reading. You can see that on the monitor, that red line that's in the middle. I really like that waveform. I think that's a really good looking arterial waveform. So I'm going to really put a lot of faith that 90/61 is an accurate blood pressure. And if you were to stand there and watch that, you would be seeing those numbers fluctuate up and down as time goes on because it is a continuous reading of the blood pressure. If you went in and stimulated that patient and caused them to get agitated somehow, you would see it immediately spikes up and the blood pressure goes up. It is a continuous reading. You aren't relying on a blood pressure cuff cycling and giving you a reading for that moment in time. This is continuous. So that monitor is showing me a blood pressure of 90/61, and then that 68 that's in the parentheses is called a MAP, a mean arterial pressure. That's a more advanced concept, but that's a number that ICU nurses put a lot of interventions into, is that MAP. So another thing that you can do with an arterial line is you can draw blood off of it. So that's a really easy way to draw blood off of your patient without having to poke them. You can, there's just like a syringe, you pull back on that syringe and you can draw fresh arterial blood. Fresh arterial blood can provide an arterial blood gas. We call it an ABG. So I'm going to call it an ABG. So an ABG will tell you how much oxygen is inside of that patient's blood, how much carbon dioxide is inside that patient's blood, what is the pH of the blood, how much bicarb is in that blood. These are all things that tell the ICU nurse, the respiratory therapist, and the ICU doctor how well we're ventilating a patient and how well they're getting the oxygen that they need. So arterial lines are probably one of my most favorite things as an ICU nurse. I'm really sad when a patient who needs an arterial line doesn't have one because it just makes everything so much easier for everybody in the team and for the patient because we're not poking them with needles as often. If a patient doesn't have an arterial line, the way we would get an ABG is in the bottom picture there. It kind of makes me cringe. I know that like the wrist area is like a very sensitive area for a lot of people, but we actually do just poke you with a needle that big and we go down until we hit the artery. We'll penetrate the artery with that needle, and then fresh arterial blood is going to flow backwards into that syringe. We can then use that blood for the ABG. So way less invasive. I mean, it's a one-time poke to have the arterial line placed, but then it's in place and it doesn't usually cause people pain to have it stay in place. But to poke somebody over and over again, even twice a day, that would hurt. You'd cause a lot of bruising and there's a lot of complications that can happen once you finish poking them there. So that's a less ideal situation for somebody as sick as Mrs. T. So most ICU patients do have an A line is the kind of the lingo that we use to call an arterial line. We call it an A line. So Mrs. T's blood gas, this is what I'm going to expect. I'm going to expect that her PO2 is just the fancy wording that we say, the oxygen level in that ABG. I'm going to expect that the PO2 is going to be low. And the PCO2, I'm going to expect the carbon dioxide is going to be high. So I want you to think back on your anatomy, physiology, all the things that you've ever learned about the lungs and the alveoli. Gas is exchanged across those alveolar capillaries. But Mrs. T's capillaries, alveoli, and lungs in general are all super inflamed right now because of the COVID virus and infection. When it's inflamed like that, carbon dioxide cannot get out of the bloodstream and into the alveoli to be exhaled, and oxygen cannot get through the alveoli into the bloodstream. The gases cannot be exchanged effectively because it's so inflamed and there's so many problems going on in the respiratory tract. Now imagine the secondary pneumonia that we talked about earlier on top of that. It's going to make it even harder to get these gases to exchange. So the CO2 is stuck in the bloodstream, can't get out into the alveoli. The oxygen is stuck in the alveoli, can't get through to the bloodstream. Therefore, I expect the oxygen levels to be low in the arterial blood, and I expect the carbon dioxide levels to be high in the arterial blood. I expect that the pH of this blood will be low, which tells me that the patient or Mrs. T has respiratory acidosis. Her blood is acidotic because of respiratory issues. So how can we fix these things? The main ways that we can fix the acidosis is with what we call continuous renal replacement therapy, or CRRT. I'm going to talk about that in another slide or two, or a bicarb drip. Bicarb is alkaline. So bicarb running continuously into her bloodstream is going to help balance the pH issue. Other ways we can improve an ABG would be more invasive ventilator settings, maybe higher pressures, more FiO2, more oxygen being delivered, proning her, which we just did, the bicarb drip or CRT. Those are the main interventions on how to fix an ABG that looks like this. So that's a little bit about arterial lines and ABGs. I hope that was interesting. If Mrs. T does not improve, this is probably what her room and her situation is going to look like. Let's talk about these pictures first. What we call that picture on the left, we call that a Christmas tree. We call that a Christmas tree of IV pumps. It's sort of just, I don't know, like nurse slang, the Christmas tree over there. All those pumps are running drips continuously into her central line or her IVs. She probably has sedation medications. In fact, I can see propofol, that milky bottle in the middle, that's propofol, that's her sedation. She probably has some kind of pain medication, maybe fentanyl, maybe morphine, maybe Dilaudid drip, something along those lines. She might have vasoactive drips, which are drips that are going to control her blood pressure. Most often, a patient as sick as Mrs. T is going to have hypotension. Now that is like, wait, what? She's been having hypertension this whole time. She has underlying hypertension issues. Why would she be hypotensive? Her blood pressure is going to be low, probably because she's maybe going to develop sepsis, or the COVID infection is going to cause a bloodstream infection. Sepsis is going to cause massive systemic vasodilation, which means that her blood pressure is going to drop. She's also going to have lower blood pressure because sedatives are known to suppress your blood pressure and cause low blood pressure issues. So there's a really good chance that that patient has some kind of vasoactive drip to drive the blood pressure up. There's also vasoactive drips that can drive blood pressure down. That would be for somebody who has dangerously high blood pressure. We do have drips we can run to bring the blood pressure down. There might be bicarb drip running up there. There might be electrolyte replacement drips running up there. There might be antibiotics running up there. There might be all sorts of different things running through that Christmas tree. I have no real way of knowing, but I know for sure that there's propofol up there because I can see it. Now the picture on the right here, I referred to CRRT, or the continuous renal replacement therapy. Often patients, when they become critically ill, one of the first vital organ systems to go or to become damaged are going to be the kidneys. But the kidneys are responsible for keeping our blood clean, balancing our electrolytes, balancing our pH, filtering out toxins, and excreting all the cytokines and toxins that are going to be floating around our bloodstream just in a normal state, but especially when you're this sick. If you lose somebody's kidneys, or if their kidneys stop functioning, like they should be, then we need to do something to help clean their blood out, because somebody who doesn't have renal function is not going to survive very long. So what does the CRT machine do? So it's that rectangular turquoise and gray machine that you see on the left of the bed there. The CRT machine is a form of dialysis. It's continuous dialysis. It's pulling blood out of a vein, a large bore vein, through a special dialysis catheter. So it's like a central line, but it's even bigger than a central line. It sits inside a vein. It's going to pull blood out of that vein. It's going to run it through the CRRT circuit. That circuit is going to balance electrolytes, fix the pH, all those things I just talked about. It's going to run it through that circuit, and then it's going to return the blood back to the patient. So as that circuit continues to run over time, all of the blood in this patient's body is going to become clean again, and then it's just maintaining. But it needs to continue running until their own kidneys can pick up in their function and take over their job again. But this is a very typical scenario for a patient as sick as this, that they're going to require this continuous renal replacement therapy. They're going to have a Christmas tree. Now, I can also see in that picture on the right, in the very back in the center, there's tube feeds running. That's the artificial nutrition. I can see the monitor. I can see that red waveform on the monitor. So I can see that they have an arterial line. On the right side of that picture, I can see a ventilator. So they're intubated or they have an ET tube. Um, a disclaimer, all of the pictures beyond my very first slide with my coworkers and I, all the pictures and graphics in this presentation don't belong to me. These are all graphics that I've found on the internet. But you can tell whoever took this picture has covered the patient's face with a pillowcase for HIPAA and privacy reasons. So none of these graphics belong to me. So we talked about the sedation. We talked about the pain medications. Sometimes a patient is so sick, we need so much control over their ventilation and their respiratory system that we're actually going to paralyze them so that they have no control over triggering a breath. That is for like very, very, very sick patients that we need tight control over them. They might be paralyzed. A paralytic would be another drip that would be running continuously. We talked about vasoactive drips. We talked about CRT. We talked a little bit about chest tubes earlier. Sometimes you might develop a pneumothorax secondary to high ventilator settings, popping a lung. The pressure inside the lungs are so high from the ventilator blowing air into that breathing tube that you can actually pop a lung, meaning that air is going to be leaking out of that contained lung, that contained sac, and it's going to be leaking out into the space around the lung. As it leaks around in that space, it's going to compress the lung. So that is a emergent situation that you might need chest tubes inserted through the rib cage to help let that air leak out. We've talked a lot about all the different IV medications that might be running, but one thing I haven't mentioned is blood products. Your metabolism is high, you might be running the CRT. Typically, a patient who's critically ill, their blood count is going to be low, so you might be replacing packed red blood cells, PRBCs. You might be replacing platelets, cryoprecipitates, or maybe whole blood. It's a little less common, the whole blood, but you might be giving blood products to these patients and anticoagulants such as heparin or Lovenox, because we know that COVID-19 causes a lot of coagulation issues, causes a lot of blood clots. These blood clots can cause strokes, loss of limbs, the pulmonary embolisms, all sorts of different issues can arise from blood clots. So we're going to keep them anticoagulated, is what we call it. They might have a heparin drip running continuously, or we might be giving them Lovenox injections. These are the kind of patients, like I said earlier, that would be requiring one-on-one patient ratio, so one nurse to one patient, or if they are very unstable and they're requiring constant interventions, multiple interventions, this might be a scenario where you will see two ICU nurses caring for one patient. In another universe, in an alternate scenario, Mrs. T might have improved instead. She might have never gone to the ICU. Her wheezing might have subsided. She would have slowly required less oxygen. She would have been able to resume all of her activities of daily livings, all of her ADLs independently. She could bathe herself, feed herself, walk around by herself, use the bathroom by herself. She wouldn't need any help with those things. They could send her home safely with a portable oxygen tank that she would slowly wean off of in the days and weeks to come. And then she would just follow up regularly with her primary and her pulmonologist. And she might have lived with some long-term complications, which I'll talk about in a minute, but she would have survived and she would have gone home. Now, in the world I've been living in the ICU, this is not the scenario that we've been seeing playing out very often. When somebody becomes this sick, they very rarely recover to the place where they can go home like this. But what I do want to say is that I have a very small window that I've been looking out of for the last year. The patients that have been going home or surviving have been the patients who never required an admission to the hospital for COVID, or the patients who never needed ICU level care. Maybe they were in that med surg unit the whole time. They were cruising along. They never got critically ill. My perspective is very biased because I've been living in a different world where we haven't been seeing the survival like this as often. What do I wish that the general public knew? The first thing I really wish the general public knew, and that everybody here today can do if you haven't done already, is have a DPOA or a living will. You can go on Google, you can find a PDF, a blank PDF, you can fill it out right now with who your DPOA is, who is your decision maker if you can't make decisions for yourself, and what are your end of life values. And you can send it to the people who are your DPOAs, and you can send it to your primary, and you're done. That's it. That's all it takes. And a meaningful conversation with the people who love you to tell them what it is that you value. Because what we've seen, and this isn't unique to COVID, this is all ICUs everywhere. Somebody comes in, they're critically ill, they can't make decisions for themselves, but they've never had a meaningful conversation with the people who will be making their decisions, which are their loved ones. And these loved ones have to live with the burden of making decisions on their behalf when they have no idea what that person valued. I don't know if they're okay with having dialysis every other day for the rest of their life. I don't know if they're okay with living on a ventilator for the rest of their life. I don't think so, but maybe they would be okay with that. I don't know. They've never told me. So you need to have meaningful conversations with the people in your life to make sure everybody's on the same page so that, God forbid, you end up in this situation, you know what to do. Surviving COVID rarely means a full recovery. Survivors, I have a little list here in front of me. Survivors might live with decreased lung volumes for the rest of their life, chronic lung damage and diseases such as COPD, emphysema, bronchiectasis, heart failure, dependence on dialysis, dependence on oxygen, dependence on ventilators, loss of limbs, like we were talking about. They have coagulation issues. They might throw a clot into a limb and have loss of limb. They might have a stroke. They throw a clot to their brain. They have to live with the side effects of a stroke and so many other things. Surviving the COVID ICU most likely means they will never be the person they were before the COVID ICU. They're going to live with lifelong comorbidities, or of course, mortality. Being critically ill is physically painful and psychologically traumatizing. People who do survive the ICU, any type of ICU, probably live with some degree of PTSD. It is such a traumatizing experience. Exceptional care from a registered nurse never replaces the love and presence of family. I think my point here being, please do everything in your power to keep yourself and your loved ones out of the ICU. The most common story of COVID exposure is someone in my household went to a wedding and then came back home to their mom. Somebody in my household went to Florida for spring break and then went and visited grandpa. Someone in my household went to the protests in Oakland, and then came back home to their great aunt. These are the stories that we heard over and over and over again. It was rarely, I mean, and then there's also never any one way to pinpoint that that was the exposure, but it's the most likely story of exposure. So when I originally, this is the second time I've done this presentation. The first time I did this was for Cal State East Bay. And when this presentation was originally done, it was back in February, March, where we were coming off of that big December and January surge. Now that we're in May, it's amazing how much things can change in just a couple months' time, especially with the vaccine. We're not seeing this as often. The stories of exposure are a little bit more convoluted now. It's a little less of people, I guess maybe the word I'm looking for is like people were a little irresponsible when we were supposed to be in lockdown during those big surges. Lockdown is lightning right now, and these stories are a little less common and a little less pertinent at this point in time because our infected numbers and deaths and everything like that are trending downward super fast. Hispanic, Filipino, and Black individuals in that order were disproportionately affected by COVID-19 from my lived experience. I don't have data. I never looked up data to back this up. This is just me speaking from my personal experience in my unit. The vaccine is safe and it's working, and the census in our situation is hugely improved since the vaccine. For the last 3 to 4 weeks, my unit has been averaging 0 to 2 COVID ICU patients. So we're no longer like a full-blown COVID ICU. We've kind of reverted back to a med-surg ICU, but we still provide care to those COVID ICU patients that trickle through. Now, this is, I think, a really powerful part of my presentation today. These are emotional impact statements from my coworkers who provided, just statements to share with you guys. So it's a war zone out there. I have become desensitized to the deaths and the family that they have left behind. This has been one of the greatest challenges in my nursing career. Despite all this, I feel that the MSICU as a group has gotten closer together. We were afraid, we were adapted, and we kicked butt. Somebody's emotional impact statement was simply dark. Kind of referring to how dark the times felt. It just felt so dark everywhere in the unit. And that's a very accurate short and sweet depiction of what was going on. Emotionally exhausted. The shortness of that, I think, depicts just how exhausted, just that's all, emotionally exhausted. My empathy very quickly turned into sympathy, and I couldn't control it. I felt the grief of the families combined with the guilt of not letting them in, and it was hard. Especially as a charge nurse, a lot of the difficult families fell on us. It was draining to be the bad guy all the time. Plus, at the beginning, all the nurses were looking to us, and we didn't know either, but we had to be strong and supportive. When I first stepped onto COVID, I squashed down the fear, the anxiety of the unknown. I donned PPE for the first time by simply taking a deep breath and approaching it with the I have an assessment to do and medications to give kind of mentality. I've approached the verbally abusive, the physically volatile, and the scabies infested in a similar way. And so I went to work each shift aiming on this method. But the frequency and intensity of this experience leaves me using the description of numbing. I feel like I've lost a significant amount of empathy and patience that made me a decent nurse and that made me me. And that loss has spilled into my life outside of work as well. I had to give myself tons of pep talk. Like someone else said, you just have to deal with it because you have work to do. I honestly don't remember being so emotional pre-COVID, but I've cried and felt frustrated during this pandemic. I've lost a part of myself to COVID. It was traumatic witnessing dying patients without their families, families watching their loved ones die outside the room. I'm still trying to claw myself out from that memory. But as nurses, we're trained to move on. We can't really dwell on such emotions because there's always another patient to care for, and the shift must go on. Brokenhearted, just remembering what we went through, and meat bag of emotions. On the top right of the screen there is a Bansky painting or piece of art. No words, just this. At the beginning, I felt kind of what it feels like to be at the top of a roller coaster before it descends. There's no getting out. This is happening. I'm in this and I'm terrified. And then we all got a little more comfortable, I think. But then emotional exhaustion set in after seeing the now so predictable path of patients taking a turn for the worse. Not enough success stories, way too much dying alone. In summary, it's been a grueling year. Somebody said, I think I have PTSD. I saw more people die than survive. And the way they died was the most horrific and isolating way. Patients would come in, I'd get to know them, I'd help them call their families, and then I'd watch them deteriorate and suffocate and suffer until the end. To feel like you know and care deeply for this person and then watch this happen to them is unlike anything I've ever dealt with in my 22 years as an ICU nurse. I am doing better now, but I was drinking too much and numbing myself on each day off. I couldn't do another surge. I will quit. I think they mean if another surge were to happen, they would quit. It's like the detective who lands the big case, or the parent of a service member who answers the door and there's a priest and another service member there, or you're in your car behind another car that gets in an accident. You do what it takes. You deal with it. You put your big boy or big girl pants on and do your job. History will look at it later, but right now I have work to do, and that's the way I look at it. And then the one I like to give this one last because I think it's really important for nursing students to hear this as they become RNs and enter the field as new grads. The incoming new grads need to be warned. They need to know that the senior nurses that they will look up to might be cold or jaded or walled off. These nurses need to know that it isn't them and this wasn't who we used to be. It'll take time, but I hope they can give us the same patience and compassion that they give towards their patients, because in a lot of ways, we are sick and healing still too. So those are some of the impact statements from my coworkers. End this on a high note, or maybe a low note, I guess. These are the daily trends of COVID-19 cases per the CDC. I pulled this graphic in the first week of May, and you can see that aggressive downward trend. That's on trend with what we're seeing in our unit. And this is daily trends of COVID deaths in the United States per the CDC. Again, I pulled this in the first week of May. You can see how quickly those COVID deaths are trending downward. And you can also see that the peak is really in tune with what we felt in our unit. That peak surge really happened in like December, January was probably the worst we ever felt it. So that concludes everything that I have to share with you guys. I would really like to open this up to any questions, thoughts, feelings that you all might have for me. And again, I thank you guys so much for being here today to participate in this.
Yeah, thank you so much, Allison. This was a really wonderful presentation. You shared some great information about the COVID ICU and your work as a COVID ICU nurse. So there is one question here that I'll read. And we did have some great thoughts going into the chat box, so you can also check that out and provide some feedback. So the first question is, can you explain or provide an estimate as to why people who are receiving the COVID-19 vaccines are still testing positive for COVID?
I personally haven't seen that yet in the ICU. I haven't seen anybody come into the ICU that were fully vaccinated. I'm hearing stories online of people who are testing positive after having the vaccine, but I haven't seen somebody in the ICU yet who was vaccinated and then became critically ill.
Mhm.
Um, Not to say that hasn't happened. I just personally haven't seen that yet.
And let's see. So I have another question here. So you mentioned that when you prone patients, they can have a cardiac arrest. If that is so, how do you perform CPR? If the patient is prone, do you turn the patient back over?
My experience, I've only seen that happen once or twice, but my experience was that we immediately flip the patient back over. You typically, if somebody's going to decompensate with being prone, everybody, like all those people that I explained the team, they all kind of stand by, for like 5 or 6 minutes to make sure that nothing changes. So all the people you need are still there. You have your hands kind of still on the blanket in the bed to help flip the patient back over quickly. So when I've seen that, we flipped them back over and started CPR from their front on their sternum, like you would expect, typical CPR. I did read research, and then I actually think that our hospital had actually sent out some info one time that there were facilities who had successfully performed CPR from the posterior. So I've never done that. I've never seen that. I would have no idea where to put my hands on their spine, but it was kind of that you technically can start CPR when somebody is still prone from their posterior. But that is, to me, that is such a wild concept, and I'd never seen it. But yeah, ideally you're going to flip them back over and do the traditional type of CPR.
Right. Thank you so much for answering that question. We have another question here. Can you share what you learned about yourself and your nursing skills during the pandemic?
Uh, what did I learn about myself and my nursing skills? I think I learned how quickly I can adapt. Um, I always like jokingly say, like, if a nurse can't find a solution, no one can. We had to get really creative with solutions in the COVID unit. We had to get creative with how to do our job mostly outside of the room. We would have IV pumps, for example, outside of the room with long IV tubing that went to the patient, just coming up with like solutions like that, just, I don't know, I guess tapping into like ingenuity a little bit and adapting. And then I definitely learned how capable I am at compartmentalizing. It was really important to compartmentalize the emotional, like, for example, there would be a family member who, they were never allowed inside of the rooms, but the rooms have glass sliding doors. So when a patient was actively dying, family could sit in a chair outside of that glass door. And we could kind of set up a game of telephone where they have a phone outside, and then we put a phone next to the patient's ear inside so the family can talk to them while they're dying. So something that I guess is a good example of compartmentalizing is there are other patients in this unit, and I have other patients that I need to attend to, give them attention and do the most for them. And I need to pretend like this really, really tragic, sad, grieving person is not sitting here and crying. I'm going to give them support, and I'm going to give them water, and I'm going to give them whatever it is that they need for support. But I also have to compartmentalize that and continue doing my job over here. I never knew how capable I was at compartmentalizing until the pandemic, which goes back to adaptability. You just don't realize how pliable and bendable you really are.
Absolutely. And we have another question here from Erica. She says, "Hi, Allison. Thank you for this presentation. It was so incredible. Do you have any tips on getting a job in the ICU? Any certs or classes that we can take as a student, or any interesting books relating to critical care?"
Hi, Erica. Thank you. I actually have done an hour-long presentation on this exactly with my clinical group last fall. And I think the main takeaways are this: if you want to be a new grad in the ICU, it's absolutely possible. I'm here in the Bay Area. I'm not sure where you are, Erica. I would say the chances of getting hired as a new grad in the Bay Area this is probably the hardest place to do it. If you can go to the Central Valley or Northern California or even Southern California a little bit, but especially the Central Valley, they hire tons of new grads. So if you're flexible in where you might move, if you focus your energy on that Central Valley, like that Fresno, Bakersfield kind of area, really high probability of getting hired into an excellent new grad residency program. Um, and then I would say in terms of certifications, absolutely have your ACLS, your Advanced Cardiac Life Support certification. I had my PALS, my Pediatric Advanced Life Support certification. I had no interest in working in pediatrics, but I thought, if an emergency room wants to hire me, I'll do that. So the PALS just kind of opens up that door a little bit further for you. And then I would get your NIHSS, which is a stroke certification. You can do that for free. Just search NIHSS certification. And the American Heart Association, the AHA, offers a lot of low price classes that provide little certifications at the end. There's like an EKG interpretation class. There's a generic pharmaceutical or medication class. So check out the AHA's website. They have classes anywhere from like $30 to a couple $100. And I think that being able to reference the American Heart Association certifications on your resume, they are rarely required. Usually the requirements is ACLS, but I think it just makes you stand out a little bit in terms of how much effort and energy you've put into wanting to be an ICU nurse. So that would be my answer, my short answer for you, Erica.
Thank you so much for all that wonderful advice and tips. We also have another question here from Suzette. The question is, how do you take care of yourself?
That's really sweet. My sister asked me that the other day. So my dog is a really big thing. Walking my dog, being outside in the sunshine, because I work night shift and I'm kind of a little bit of a vampire. I really actually am a morning person. So having a dog forces me to get outside and being the sunshine. So going on walks is really important for me on my days off. I have a Peloton, so that's how I get my cardio in. I really like that. That's a really good way to de-stress. Self-care, it just in terms of like taking like really nice bubble baths and things like of that nature kind of help me unwind and get a really good night's sleep. And then I'm a really big family and friends is really big for me. So moving back to the Bay Area was very important for me. That's why I moved back to the Bay Area. So being connected with my family and my friends here locally is the other part of how I take care of myself. So that's a very sweet question.
Thank you so much for sharing kind of like your self-care routine. We
Yeah.
also have another question here. What are some of your takeaways as a frontline worker, a nurse, an educator, and as a human being from working on the front lines of a pandemic and directly with COVID patients? And what do you think we as future nurses or the general public can take away from your experience?
Key takeaways. Wow. I think some key takeaways, I think it would be, I guess I really want to say I wish people had listened to science from the beginning. I think that's a big key takeaway. I guess, I think we've all heard that like on average, like the giant pandemic happens like every century. So, in a century from now, I don't think that that advice is still going to be fresh in people's brains. But I feel like if the pandemic were to happen again in the next few years, I hope that people would hit the ground running, believing in science from the beginning. Because I think there was a lot of doubt about whether the vaccine really was going to make an impact on infection rates. And I think that the proof is in the pudding. So that's really a big key takeaway. And then I think that for as far as like entering the field of nursing and entering in kind of the presence of these nurses who have survived this, um, this is typical of like a lot of new grads. It was typical of me as a new grad. Like, you walk in and on one hand you think you know a lot, and on the other hand you realize you know absolutely nothing. So I think please approach your coworkers, especially the ones who have been dealing with COVID, approach them with the I want to learn from you kind of mentality. And I value all of your experiences in this career, and I want to learn from you. I think being approached in that way is going to be important for people, to feel like we're recognized for a kind of what we've been dealing with. So I think that's my advice.
Thank you so much for providing that advice. We also have one more question. I think we'll take this as the last question of the night. Can you expand a bit on COVID and multisystem inflammatory disease? Is that caused by sepsis? And what do you think of the use of anakin, I have no clue how to say this, but ANAKINRA, anakinra.
I
Thank you.
haven't heard of that one.
Yeah.
Yeah, so I can't answer that part, but in terms of like the systemic inflammatory response, or SIRS, I think is what they're referring to. So multi-organ dysfunction system, or MODS, multi-organ failure, is really common in the ICU. The most common culprit is severe sepsis. Severe sepsis tends to happen in the COVID population because their immune system is so suppressed from trying to fight COVID, and that COVID just kind of destroys the immune response. Now, I think the best way to describe this is that when you are this sick and fighting something as aggressively as you're fighting something when you're in the ICU in terms of infections, you do go into an inflammatory state. Your inflammation system is a mechanism of trying to destroy the invader. But it's a double-edged sword, because then your inflammatory response suppresses your body's ability to function normally. So when your lungs become inflamed, your lungs stop functioning. You develop fluid in that space between the alveoli and the capillaries. You can't exchange gases. Your lungs and your kidneys are linked, right? Like the hormones that control one kind of control the other. When you start to lose your respiratory system, you tend to lose your renal system. You lose your renal system, you lose your hepatic system. You lose your hepatic system, you're going to have GI problems. It all tumbleweeds on itself. And each system is seriously intertwined with every other system. So the systemic inflammatory response tends to come from the infection becoming bloodborne or bloodstream, which would be sepsis. And that's but then also the systemic inflammatory response is all the cytokines and all the inflammatory processes that are happening up here. All those cytokines are going to start traveling through your vasculature to other organs, which can trigger them to have an inflammatory response too. So it can kind of be either of those mechanisms. I hope that answers that question.
And I also looked up what anakinra is, and it's a type of medication. I believe they're using it for COVID. It's called Kineret. I'm not sure if you've heard of that or used that in the ICU setting. Possibly
I
not.
haven't seen our providers prescribe that. I'm not familiar with that. And to be honest, I've been kind of bad about keeping up on like new trial drugs and stuff like that. Actually, that's kind of been my mentality about all news and reports on COVID. I kind of felt like because I'm living it, I don't need to read about it on my days off. So I'm not familiar with that at all. I wish I could answer that question, but I don't have an opinion because I've never seen it or heard of it.
Okay, perfect. Thank you so much for answering all those questions, and thank you all for joining us today. So we have a few announcements before we end this webinar. First, the Nursing Science Committee will be having another journal club on June 2nd at 6 p.m. and the topic will be on public health, and we'll be having a special guest speaker, Dr. Sharon Goldbard, join us that day. So stay tuned on our social media accounts for more information. Additionally, if you attend 2 journal clubs and write a 250+ word reflection and send it to the Nursing Science Committee Chair, Jessica Folk, whose email is right there on the screen, you can qualify to purchase a Nursing Science Committee graduation honor cord for $19.99. And all these details are available on our CNSA website, which is cnsa.org under the Nursing Science Committee tab. So once again, we'd like to thank all of you for joining us today, but especially thank you to Allison, who took the time to create this presentation and speak to all of you about her experiences and role as a COVID ICU nurse. So thank you all and see you next time.
Thank you so much.